Wonderful. Well, as I begin sharing my slide, I'd like to share with the audience today is a little bit of a tiny bit of an experimental presentation. I'm going to do a bit of a multimedia presentation, and we'll know whether I'm invited next year or not, whether the experiment worked. But all jokes aside, I'm going to share with you the issue of our need to change our healthcare system. We need to override a healthcare system and just do something that's very different than what we're currently doing. And so what I'm going to do is give you my insight into our work and share with you the approach I think we need to take. And I'll share with you some two clinical cases that demonstrates how we carry this out. So essentially,
Dr. Montgomery, before we begin, there's a on the top right, there's another bar. Can you move that to the other screen, maybe?
Okay.
Perfect. That's fine. Perfect.
Okay. Sorry about that. All these technical problems here. So we're in a healthcare crisis. Many of you may be aware of that. I'll have one slide for this. This could be made, this could be a talk in and of itself. What I will say is that the data shows that our life expectancy decreased suddenly from the year 2019 to 2020, and then from 2020 to 2021. Of course, that drop in 2019 preceded the recent pandemic, so we can't just put it on the pandemic. Prior to this, from 1995 up, we had an increase in life expectancy. It began to plateau and maybe had a slight drop in 2014, but had a drastic drop in 2019. We're all aware of the increased prevalence of chronic illnesses, diabetes, hypertension, obesity, and it's affecting the young and old and alike. And so sickness has become the norm. So needless to say, a paradigm shift is needed. And my theory is that lifestyle intervention should be the first line treatment of choice for both prevention, control, and also reversal of chronic illness. And I want to emphasize the need to use lifestyle for the reversal of chronic illness, because most of us are in a situation in this society where we're not trying to prevent things. For the most part, we need to deal with disease reversal. And that's where we really need to use lifestyle intervention. Now, what I'll say is, what is this paradigm shift? So it's one thing to say lifestyle intervention. However, if someone is sick in the hospital, if they're on a ventilator, and intubated in the ICU, you can't just, take them off life support and say, just eat fruits and vegetables and exercise. So you have to integrate this aggressive lifestyle intervention with an existing allopathic medical treatment that we have. So we put together this integrative health approach. And so the foundation of this integrative health approach, it combines allopathic treatments, such as medication treatment, surgery, and the like, on an as-needed basis, but it doesn't strictly rely on those things. So this combination of allopathic approach with both natural and regenerative therapies is the core aspect of this integrative health approach. So first step is that we try to stabilize individuals who are acutely ill. That starts with evaluating their condition, weaning them from prescription medications as needed, and weaning them from procedures. Now, the reason why I emphasize weaning prescription medication and procedures is that we have to recognize the double-edged sword of these procedures. And many of you may be aware of the fact that the number one cause of illness and death in the United States is cardiovascular disease. Number two is cancer, but number three is medical treatment. So when we prescribe medications and we prescribe, procedures, yes, there's some potential benefit to these prescriptions. However, there's also a potential risk. And oftentimes when we're excessive in prescribing these things, the risk outweighs the benefit. Then we need to, next step is integrate natural lifestyle intervention. So oftentimes we get patients that stabilize on 2 or 3 blood pressure medications, and then the doctor says, okay, I'll see you in 3 months or 6 months. But we shouldn't stop there. Integrating lifestyle interventions to enhance natural healing is an important thing. These medications and surgeries do not heal the body heals itself. Then we have to utilize target micronutrient therapies as needed. And then there are so-called advanced regenerative therapies that are also beneficial for individuals with advanced illnesses who need more accelerated healing. Examples include infrared sauna therapy, There's ultraviolet light therapy. There's ozone infusion therapy, external counterpulsation therapy, and there's also hyperbaric oxygen therapy. And of course, making a rapid move into natural therapies is mesenchymal stem cell therapy. So these are all therapies that in our practice, we have either started or are planning to start to integrate in the care of our patients. So how do we look at this integrative approach? So what does the nutritional intervention look like? Many people follow the standard American diet lifestyle. Many individuals who are consuming fast foods on a regular basis, many of them are addicted to these foods. So it's not just a matter of giving them a pamphlet and say, well, eat your fruits and vegetables. We have to treat these current lifestyle habits as addictions. And so you have to create a program around it. So what does that look like? Well, there's detoxing protocols, there's fasting and cleansing that allows the body to jumpstart its metabolic switching processes. It also changes to taste buds. You have to support them with nutritional classes, the comprehensive clinical detox programs. So what we've learned in the nearly more than 2 decades that we've been applying this approach, that individuals need support, and they need support on an ongoing basis. There's also advanced recipe design, small group shopping, and gardening tools. So we've created an online community to help substantiate and support these different approaches. How about targeted micronutrient therapies? I'll see individuals coming in with cardiac arrhythmias, with uncontrolled blood pressure. We may have to measure their intracellular magnesium level, for example, or they may have a deficiency in coenzyme Q10. Many individuals are deficient in vitamin D. So we may have to use targeted micronutrient therapies to help correct these deficiencies in a more accelerated manner. So some of these can be done intravenously, and some of these can be done orally. Also, there's an approach to test for certain micronutrient deficiencies. There's some specialized testing that can be done. Also, I should mention that many individuals are loaded with different toxins, different metals, xenoestrogens and the like, and these things need to be tested for as well. And these abnormalities need to be corrected as well. So there's a targeted approach that has to be utilized from the standpoint of the individual biochemistry. What about fitness? Well, oftentimes we'll tell patients that, well, just exercise more, walk, etc. What we've done in our practice, we've incorporated trainers. We have trainers on contract. We have certain days at a gym, and we have our patient go to that gym and work out, and the trainers put them through certain workouts. These are certified trainers who intentionally work them out to improve their core, improve their balance, improve their cardiovascular fitness. So it's not just a matter of telling people just go and walk every now and then. We have to prescribe fitness in an accurate manner as well. Then there are also physiological functional correction, and from the standpoint of using chiropractors, acupuncturists, and the like. And these are done in a targeted fashion based on special needs. These are some of the advanced regenerative therapies that are integrated. External counterpulsation, we have 2 of those devices in our office. This works very well for individuals with advanced cardiovascular disease. Ozone therapy works very well with people with inflammatory disease or systemic illnesses and cardiovascular disease. And soon to be coming to our practice, mesenchymal stem cell therapy is making its way on the scene to help out, certainly with patients with arthritic conditions and other chronic illnesses as well. So all of these therapies need to be integrated. Oftentimes individuals will, go to the supermarket and take a supplement, or they may go to one care person to get, acupuncture, et cetera. But these therapies need to be integrated under one clinical home where you have a clinical team that's looking at the progress of the patient and looking at how these therapies are working synergistically and how effective they are, making adjustments as needed. So that's the approach from the integrated care standpoint. Now, here's clinical case 1. This is a patient, many of you may know him, you may recognize him. We're going to share our approach with this patient. He is a 62-year-old man. He's a retired NFL player. He actually happens to be in the Hall of Fame. So he came to our center and wanted a cardiovascular workup. He wanted to get back to exercise. In fact, he wanted to get back to training his body to get near his performance level. He had not seen a physician in nearly 15 years. He did report a family history and somewhat of a personal history of hypertension, but wasn't checking his blood pressure regularly. However, he didn't have any symptoms whatsoever, no dizziness, no chest discomfort, no shortness of breath. In fact, he played with his grandkids when he was at the center. He showed me a videotape him doing cartwheels with one of his grandchildren. However, when we took his vital signs, he was a little overweight, but what caught our attention was initial blood pressure 191/114. And so here's someone who had not seen a physician in 15 years, and he's coming in with this blood pressure, which many people would say, hey, this is stroke level. So despite him not having symptoms, et cetera, this kind of blood pressure is something that gets your attention. So then the question becomes, what's the next step? What should we do next? Well, the options are, one, do we send him to the emergency room? This is a common approach. And I think to do this would not be a bad thing. Should we start him on medication? This is certainly, I would think, would be the least thing you should do, someone with that type of blood pressure. The other possibility would just to simply start him on a lifestyle intervention. Forget the emergency room, forget the medication, just say, why don't you just have, raw fruits and vegetables? Is that a reasonable approach? So the question is, with this person with 191/114, what approach should we take? Well, let me sort of share with you a video clip and give you some insight in terms of our discussion about this patient and how we went about giving some consideration. Let's look at Mr. Green's stress test.
On his stress test, he had good functional capacity, went for a good period of time. His blood pressure response was normal. It started at 191/114 in the office, and then after the end of the exercise, it was 180/100.
Okay, that's pretty good. And EKG changes, anything? Let's kind of scroll through the EKG stress real quick. So one, even though you had a very high blood pressure, there was no evidence of any stress on the heart, a heart attack going on, which is important. The stress test didn't show any changes consistent with ischemia. What should we do? I mean, blood pressure 191/114, a lot of people send them to the ER right away. So there you go. Blood pressure 191/114. And so what should be done? I don't know if we have a chat feature. I'm just going to throw these questions out at the audience. There are benefits of going to the emergency room. There's an inpatient observation while normalizing the blood pressure. You can rapidly normalizing the blood pressure. That's a possibility. More rapid blood test results. So there are some benefits of going to the emergency room. There are probably others. The benefits of sending the patient to of not sending the patient to the emergency room. Well, you avoid the extra costs. You avoid extra emotional stress. Sometimes you go to the emergency room, you're there for about, an hour, 5 hours. There's sometimes there are iatrogenic medical events that can occur in the in the medication or emergency room rather. So the question is, what would you do? I don't know if there's a chat feature, but if there is, feel free to leave your comments there, and we can address these questions, in the question and answer session. Now, I'll tell you, regardless of what we did at that time, this patient did continue to see us over a period of really 30 days. And what we saw in the first 2 weeks, less than 2 weeks, is that his peak systolic blood pressure, which was initially 191, it went down to 126. Notice the suspicious gap in measurements there, so you can inquire about why that's the case. The average systolic blood pressure, we did recheck his blood pressure multiple times during the first office visit. The average systolic pressure was 167. It went down to 122 over time. And this is all within 11 days. And the peak diastolic went from 114 down to 86 in 11 days. And the average diastolic went down from 99 to 78. We also saw a significant reduction in the heart rate on average from 83 to 72. This is all in 11 days, and his weight went down considerably in 11 days as well. Now, at the end of about a month of his intervention with us, we had a total cholesterol was 207, went down to 183. The LDL cholesterol went down significantly, and he did have improvements in other clinical biomarkers. And granted, there's more room for work to be done here, but this is what we saw in the first 30 days. So his systolic blood pressure was reduced in 2 to 3 days, as you saw in the graphs. Diastolic blood pressure reduced in 2 to 3 days. Heart rate was reduced significantly in 2 to 3 days. And he lowered his cholesterol, glucose, and lipoprotein. So we did get significant weight reduction as well. So we saw very significant changes in just a couple of days. And you can probably guess from this part of the presentation what decision we made, but we can examine that more definitively in the question and answer session. Now, the second patient I want to share with you is a patient came in with perhaps more chronic illnesses. He was a 63-year-old man who had a history of a myocardial infarction back in 2005. So this is maybe 16, 17 years ago at the time we saw him. Triple bypass in 2007, history of hypertension and diabetes. Also had a history of chronic kidney disease. And also his BMI was 43.13. So the integrative health intervention that he underwent consisted of step one, we had to clinically stabilize his condition and wean his medication. So he was not acutely ill on presentation, even though he had that horrendous history of heart attack and heart failure and kidney failure. He was not acutely short of breath and that's an important thing to consider. So it's always important to evaluate the patient's clinical condition upon presentation. So the next step was to evaluate, could we wean his medications safely? And so the decision-making process starts with patient safety first. Is the patient decompensating? Do we need to be monitored on medication? Do we need to admit him to the hospital? In this case, no. The general therapeutic effectiveness that need to be considered. Could it be better to hospitalize patient in some cases? Some cases it is better to hospitalize patients. In some cases, they can improve faster in the hospital under close observations. Also, you can get more diagnostic testing done faster in the hospital and done more quickly. However, there's also the medical liability issue that one must consider as well, because obviously when you're doing something a little bit off the beaten path or something a little bit unorthodox, you have to consider the potential risk of someone wanting to sue you, et cetera. That risk exists in any form of clinical medicine. So the approach was, let's look at his medication list. He was on about 2, 4, 6, 8 medications. And so we have to consider which ones should we wean first. Now, looking at this list, I'm going to share with you the approach we took in weaning his medication. We didn't, jump and wean all of them within the first day. The weaning process took place in the course of maybe a week or two. We started with the insulin pump. Now, this gentleman was on an insulin pump. His blood sugars were well controlled on insulin pump, and he did report having some episodes of hypoglycemia, and we were concerned about having more episodes of hypoglycemia once he got on a nutritionally rich diet. So we essentially had him put the pump on 0. We took the aspirin off. We felt that wasn't needed. That was the next thing to come off. The atorvastatin went next. We felt that was reducing his coenzyme Q10 levels. He did have congestive heart failure, and that may have been contributing to that. And we felt that we'd be able to control his lipids effectively on the nutritional regimen. The ranolazine wasn't helping. That drug only helps out with symptomatology. Clopidogrel wasn't necessary. He did not have a stent within the last year. The valsartan may have been contributing to his renal insufficiency, and we felt that we needed to add another agent. We can add something that was not an ACE or an ARB that we can discontinue. And the Ozempic went pretty quickly. Many of you may be aware that, this is one of the GLP-1 agonists, which is nowadays very popular for weight loss. And this person was morbidly obese. We had no problem stopping this medication. We felt that on the lifestyle intervention that we would place him on, if he followed it, then he would have no trouble losing weight. And the last one to go was the bisoprolol, which we weaned pretty carefully. But medication weaning is an approach that is one that we take very seriously, because it's a very important part of the health maintenance of the patient. So the next step was nutritional intervention. Step one, we removed all toxic and potentially toxic food from his diet. No dead animal flesh, as we refer to it as. We removed all dairy, removed eggs, all cooked foods, removed all pasteurized beverages and alcohol. We put him on a strictly raw plant-based diet. And he consumed alkaline water, cold-pressed juices, plant smoothies, seasonal fruits with seeds, raw vegetables and fruit, gourmet raw foods that we prepared at our center. And we put him on a time-restricted eating pattern. He ate between 11 a.m. and 4 p.m. He drank alkaline water prior to 11 p.m. and after 4 p.m. So he followed this regimen. Within about a couple of weeks, we started him on an exercise regimen, about 5 days a week. This was with our trainer. It was essentially, core exercise, strength exercise, and there was some high-intensity interval training workouts that was combined with that. Beamer therapy was a therapy we used that helps with microcirculation. He also was started on infrared sauna therapy. It's also known to improve nitric oxide production. There's great data out of Japan showing its effectiveness with patients with congestive heart failure. It also improves fitness level. And then he did get ECP therapy, given his known history of coronary disease, which was effective in improving his circulation. So all of these therapies were integrated. And here's what we were able to find. In summary, medication stabilization, clinical assessment, medication weaning, nutritional detox. We removed the toxic foods, important, and started him on a raw plant-based diet. We started high-intensity interval training, outdoor aerobic training, strength training, and all of these therapies were integrated in while we were seeing him in the clinic. And we were monitoring him clinically as well. So this was all integrated in his medical therapy, regenerative therapies, infrared sauna, ECP therapy, Beamer therapy, and the like. So what were the outcomes? His ejection fraction, that's the percentage of blood that the heart pumps out with each beat, started at 30%. Within about 4 months, it was up to 45%. The filling pressures on the right side of the heart, that's the amount of pressure that's inside the lungs. And if you have a heart that's weak or stiff, you have increased pressure inside the lungs. You want that to go down. It went down from 42 millimeters of mercury down to 28, which was in normal range. So he had decreased filling on the right side, which was a good thing, and an increased pumping function of his heart. His kidney function, creatinine, initially went up, probably due to some early dehydration, but it came down. So the creatinine that came down, that's a sign of improved, what we call glomerular filtration. So that's improved kidney function. We can see the glomerular filtration rate. That's the rate in which the kidney is filtering the blood. Went from just 29% all the way up to 82%. 82% greater than 90 is the absolute normal. You want it at least greater than 60. So he was well above needing dialysis. At 29%, he was only 14 points, but 15, 16 points to where he would need dialysis. Below 15 GFR consistently, you're on dialysis. So he's pretty close to needing dialysis. And if you compare the cardiac function with improved kidney function, there was a correlation. So we think that some of the kidney failure was due to heart failure, and some of it was due to intrinsic kidney problems as well, both of which were correcting under the nutritional regimen. His glucose level, I wanted to show this, did not change significantly. There was some initial drops. We took him off the pump. It went up a little bit. So his glucose hang around in the 90s. But despite the fact that the glucose level bounced around, his hemoglobin A1C went down drastically in a period of about, so this is about 5-6 months. And so we had a drop in the hemoglobin A1C, and we've seen this on our research data. His weight in about, this is 6 months, he had about a 71-pound weight reduction. This is after we took him off one of the well-known weight reduction medications. We were able to reduce his BMI as a result of that. So what's the science behind it? We've actually published our work, and we've shown that a defined plant-based diet in an outpatient setting, which is what this is a plant-based diet in outpatient settings effective in reducing hypercholesterolemia, reducing blood pressure, and we can do it while at the same time reducing medications. We showed that we can reduce atherogenic molecules, inflammatory molecules, and all this can happen in just 4 weeks. Now, it's important to understand that we intentionally looked at the effectiveness of this in 4 weeks, because oftentimes when we think of lifestyle intervention, we say, well, it takes, months or years for these things to happen. And this person needs medication now because their blood pressure is high now. But no, we've shown scientifically that these things can happen within 2 to 3 days. And certainly published the data showing it happening within weeks. We've showed a case series of patients with heart failure that showed improvement. Here's some of a snapshot of some of the data. The weight within from baseline, and this is a group of 31 patients in our study, a very significant reduction in weight in 4 weeks, similar with BMI. Our waist circumference went down significantly, all within 4 weeks. Systolic blood pressure went down, and these changes are happening in the setting of medication reduction. Also, you see hemodynamic effects, ejection fraction improved, LV mass went down, so that's the amount of thickness and enlargement of the heart. The overall stroke volume improved, cardiac output improved. We saw inflammatory markers go down by 30%, cytokine markers go down by 23%, all in just 4 weeks. Inflammatory markers of cardiovascular, the vascular system go down. So we see these things happen drastically, and even hemoglobin A1C, which in this group was only a pre-diabetic group, we saw a very significant reduction of 3.4% reduction in hemoglobin A1C, despite the fact that the blood glucose didn't show any significant reduction. So you may ask, well, why is that? The hemoglobin A1C is a measure of the average blood sugar over 3 months. How can you show a reduction in 4 weeks or 1 month? Well, the other thing that influences hemoglobin A1C is fluctuation in blood sugars. And probably the main contributor to fluctuation of blood sugar is probably postprandial blood sugar. So the blood sugar probably is elevated after you eat. On this defined plant-based nutritional regimen, I propose that we reduce the fluctuation of blood sugar enough to where it had a very significant reduction in hemoglobin A1C. 3.4% is much greater extent of A1C reduction than you can get with any medication. So you can see how these two patients, not only did we control their health conditions, but the first patient is starting to run much faster. The other patient's much leaner. He's working out in the gym. We're returning them to their youthful ages. We're activating the champion in them. And so what we decided to do is to actually create a Docu-Series, which is an educational Docu-Series that we are showing the effects of our patients going through these interventions. And we're displaying that to the world. And the Docu-Series is called Heart and Soul of a Champion. I'm going to show you, this is the experimental part, the first episode of season 1. Now, season 1, we started with some retired NFL athletes. So that's one group. Season 2 is already being filmed. Season 2 is going to be chronic illness in women. So we have a broad scope of women from different walks of life. Season 3 is going to be another group. So we have a variety of people that we're working with. So season 1, I'm going to show you next. And so we'll take questions after we're done there. So what I'm going to do now is stop sharing my screen here.
I can do it for you, Dr. Montgomery. Hold on.
Okay. Yeah. Hold on 1 second here.
Okay.
Okay,
Now,
there we go.
now reshare your screen.
Okay, hold on 1 second here. Let me take this back here. Okay, so here is episode 1 of Heart and Soul of a Champion. With the 25 years of practicing cardiology and internal medicine.
Dr. Montgomery, pause 1 second. Can you hide meeting controls on the top?
Sure. I'm sorry?
On the top right, go to the 3 dots on the right, and then click.
Yes. I thought it would hold over from the last time. Okay, there we go. All right, let me start it from the beginning here. Oops. Am I still sharing?
Yep, it's perfect.
Over the 25 years of practicing cardiology and internal medicine, I've treated patients with many advanced diseases. Following these patients, despite the advancement of technology that we've had, the patients continue to get sicker and sicker. In my busy practice, my health started to decline. I started noticing that my cholesterol went up, my blood pressure was up, and I did not want to take the same therapies I was prescribing other patients. I'm Dr. Baxter Montgomery, and I've been practicing in the world's largest medical center for more than a quarter of a century. Our center is quite unique. The Montgomery Heart and Wellness Center is located here in Houston, Texas. We have state-of-the-art diagnostic and therapeutic tools. I have a background in biochemistry. I have medical specialties in internal medicine, cardiovascular disease, and cardiac electrophysiology. So I started doing my own research. I got into nutrition. I ran across a local individual who was an expert in doing nutritional detox. And I went through a natural detox in cleansing my system over a period of 33 days. In that period of time, I felt amazing. I felt like I was 18 years old at the age of 35. This caused a light bulb to go off. If this can cause me to improve, this could have an impact on my patients. The body has the ability to heal itself when properly nourished, rested, and hydrated. We know this is effective in getting people back on their feet. However, I have a hypothesis that this intervention is even more powerful than that. This intervention, I think, can get people back to peak levels of performance. So we brought together a group of athletes who had performed at peak levels at some time in their lives. And we're going to work with these athletes, despite the fact that they're coming in with chronic ailments such as high blood pressure, heart failure, arthritis, and many other chronic illnesses. It is our impression that this intervention not only will help their bodies reverse these chronic illnesses, but it would also help their body get back to a level of peak performance. If you can go back and turn the clock, go back to a time where you were at your peak performance, would you do that? This is Heart and Soul of a Champion, Athletes Edition, Season 1. I've been working with Wendell Mosley for several months, and I thought, based on the previous findings, he would be a perfect candidate for this program. He had gone through our detox program successfully. However, there were a few setbacks that he had that affected him emotionally.
So I didn't really start playing football until like the 6th grade. By the time I was in the 11th, 12th grade, now I was getting a lot better and, into a starting position on the high school football teams. A cousin of mine that gave me a call one day and said, man, are any schools still recruiting you? He said, well, I got a place that wants to look at you. I said, wow, let's do it. So he said, yeah, so I got a coach up at University of North Texas. And so I walked when I actually started and led the team.
His initial reason for seeing us was that he had had a previous diagnosis of prostate cancer. So he underwent the prostatectomy. He had a successful procedure. And so he was seeing us after the fact. However, despite him having gone through the surgery successfully and doing well, some of the numbers were not looking ideal. And his urologists were telling him that, hey, maybe we're going to have to put you on hormones or some other type of medical therapy. And when he asked him again about lifestyle changes, he was given no answer. And he was feeling demoralized. Oftentimes patients are just focused on, well, my numbers are going up. And he was just focused, well, the numbers are going up, so I'm going to get the other test. What does the next test show? What does the next test show? I wanted to get him out of this mindset. I wanted to get him out of this frame of work. I wanted to get him back on the football field, on the gridiron, to take him back to a time where he had other goals. I want him to put him in a space of going after goals beyond improving laboratory tests. This was going to put him in a different mental space, and this was going to help him heal his mindset about his disease state. So I've known Kenny Banks for a while and met him through his work with hyperbaric oxygen therapy, and had worked out with him once or twice, and I knew that he was physically fit.
My name is Kenny Banks, 55 years old. I'm a former world-class high jumper and competed on the professional track circuit in the 80s to the mid-90s. Been in sports pretty much all of my life. Tried out for a couple Olympics. Love to still work out and stay active. And that's just a big part of my daily routine, and sports and athletics keeps me healthy.
When I started this project, my idea was to have him come in and push the rest of the group because I knew he was physically fit. However, here we are on day one. His blood pressure looks great, but after doing a stress test, my PA notifies me that he has a significantly abnormal stress test. And when I reviewed the stress test, had very significant EKG changes consistent with coronary disease. My concern is that someone like him, being seen by the typical cardiologist, would be scheduled for coronary angiogram and a possible stent placement. The question is Kenny Banks at risk for heart attack or even sudden cardiac death? Our initial evaluation of Daryl Green when he came in, he seemed to be in pretty good shape. He didn't have any significant symptoms. He didn't have any symptoms of chest discomfort or shortness of breath. He had pretty good energy level. So I felt that he would be someone that we'd be able to start off with and start getting, to that higher level.
I am a former professional football player, 20 years in the NFL, with the team formerly known as the Washington Redskins, presently known as the Commanders.
Our problems with Daryl Green is that he presents to us with, number one, reporting that he has not seen a doctor in 15 to 20 years. And the problem with that is that he essentially has no baseline data for us to evaluate. The other problem that he presents to us with is that he's lived the standard American lifestyle from a dietary standpoint. Now, he does exercise from time to time, but he hasn't exercised in about 2 years based on his report, at least not on a regular basis.
I'd like to live long. I like to live long because I like to have an extended impact on the world. Super Bowls, Hall of Fame, all that stuff is great because that's a tool in my hand. That's what drives me. So if I can be healthy and be there and participate and use even some of the foolish things of this world, run fast at 62 and people go, and then now I got a conversation with you.
Upon the initial set of vital signs, my staff came to me and told me that his initial blood pressure was 191/114. So that raised my eyebrows. When a patient comes with a blood pressure like Daryl Green has, 191/114, this is a blood pressure that's at a level that's considered stroke level. 9 times out of 10, or maybe 9.5 times out of 10, a doctor will send you straight to the emergency room, especially if it's a clinical setting where you cannot get CT scans or other types of imaging. This is a medical emergency. This is the type of blood pressure that doctors typically treat urgently in the hospital, in an emergency room, right away. The other thing we found is that Daryl Green has blood vessel disease. Now, we refer to this as endothelial dysfunction. Essentially what that means that he has blood vessel disease, which could mean he's predisposed to a heart attack or stroke or some other type of vascular problem. When I started this project, I had the goal, the vision, to take retired athletes and take them to a level of physical performance that was either near or at their previous peak levels of performance. The tricky part about Daryl Green is that my scientific mind is struggling with my human football fan mind. My scientific mind, my medical mind, is saying this individual is at risk for heart attack, stroke, sudden cardiac death. My sports fan mind is saying this person's physically fit. This person can run a 4.340. This person is superhuman. And I'm struggling within with this individual. And I know that nearly half of the individuals with cardiovascular disease present with sudden cardiac death as their first symptom. And now we have to make a decision. Should that be send them to the emergency room or not? I met Raymond Wadi through Daryl Green. The night before the first visit, Daryl calls me and says, hey, I have this friend, Raymond Wadi, and I just found out after talking to a mutual friend of his that he was recently diagnosed with congestive heart failure. So last night we talked, and I talked to Raymond. His wife is on the phone through speakerphone, and I just shared with him that I think what we do can help. And so he decided to come in. He still wasn't sure what he wanted to do even after coming. However, he completed our intake form, and as of now, he tells me he's all in.
Most of the people that know me call me Ray. If you really know me, they call me Stack, because that means I grew up with you. And probably more known as Coach Wadi. I was fortunate enough to earn a scholarship to go to college to play football. I was an undrafted free agent, signed with the Washington Redskins, and ended up being fortunate enough to make the team and spent a little over 3 years with them. So I ended up going to the St. Louis Cardinals, getting released, the last cut. I left there and came back to Texas as student taught. Left Kingsville and went to Canada and played in the CFL with Edmonton and British Columbia. Left Canada, came back to the States in the newly formed United States Football League, and finished my career in '84 in San Antonio.
So Mr. Raymond Wadi comes in, and I look at him. He has a very, very distinctive limp. He's obese. He is wearing an external defibrillator. So he's not the perfect picture of health. My concern with managing a patient with heart failure is that we have two major problems with heart failure. One major problem is that heart failure patients can become very ill and die from overall poor circulation. We call that pump failure. Overall poor circulation leads to kidney failure, liver failure, GI failure, and brain dysfunction. And individuals in this condition are very, very sick and very, very hard to manage. The other situation with heart failure is that heart failure patients are at risk for sudden cardiac arrest. 1 minute they're up talking to you, the other minute they collapse in death. So sudden cardiac death or slow pump failure. These are two very difficult things that we deal with patients with heart failure. Raymond Wadi's heart failure is so bad that he has to walk around with a device about the size of a transistor radio to monitor his heart in the event that he suffers a cardiac arrest.
In 2019, I was diagnosed with cancer after having a complete hysterectomy. Talking about a good husband, he was there with me from start to finish. We cried together, we prayed together, but we got through it. It was very hard. Some of the things that I went through, some men couldn't stand it. He stood it, and he stood with me. I tell you, that's God. That's a godly man and a loving husband. And we've had other challenges. I lost my bonus son. He was my godson, but I call him my bonus son. In January of 2021, he was hit by a car. That was devastating to me, and he was only 29 years old. April of 2021, I lost my dad. In January of 2022, I lost my only grandson that was 17. I'm still having a hard time from both of those, and he's been right there by my side. So, it's been a lot for me.
I lost my brother.
In March
To brain cancer. Leading up to before I was diagnosed, I had been feeling very tired, very fatigued, and I started having shortness of breath. And so my wife said, well, you need to get an appointment. So I got an appointment with my PCP. He did a EKG, and they found an arrhythmia, abnormal heart rhythm. So he sent me to the cardiologist. The cardiologist called me in and told me that I had congestive heart failure. That was a lot to unpack.
When we got that news, we were both just like dumbfounded.
It was just a lot of unknown uncertainties. What did that mean, congestive heart failure? Am I gonna have a heart attack? Or is my heart gonna stop working? Which basically is the combination of all those things that could happen.
The most important thing that I noticed about Wadi, he has this continence, his facial continence of hopelessness. That is the most worrisome symptom that he has, in my opinion. That symptom is the most difficult symptom to deal with any patient. When a patient has lost hope, then that patient is a patient who's very difficult to treat. My main intervention with Raymond and Wadi on day one has been to introduce a sense of hope and direction. What we're doing with him today, come up with a game plan toward healing your heart. And this is the strategy. And this is our plan for victory. I'm taking him back on the football field, and I'm giving him a plan for victory. And this time the victory is to heal his heart. Well, during his treatment on the ECP bed, I walked up to him and I said, well, what was your best time in the 40-yard dash? And he told me it's 4.49 seconds. And I said, oh, great. That's your goal. Your goal is 4.49 seconds. Now, he looked at me and laughed with a look, hey, this sounds ridiculous. I said, no. I had a very serious face. I'm very serious. Your goal is 4.49. And I talked to my staff and I explained what we were doing. I said, look, Mr. Raymond Wadi's best time in the 40-yard dash was 4.49. Our goal for him is 4.49. Every time you see him, I want you to say 4.49. It's a realistic goal, and it's a goal that we want him to make his own goal, even if it's a lifelong goal. 4.49. One thing we've dealt with in our approach to treating patients with chronic illnesses is a paradigm shift in our thinking in terms of how people should age compared to how we currently age. If we look at individuals who are aging, who are developing chronic illnesses, our natural thought process, or at least our current thought process, is there's a debilitation over time. Similarly with athletes, but the everyday individual. But what we've come across is a different way of thinking about this, based on our historical clinical evidence and clinical experience. The paradigm shift that we have come to is that individuals should improve their performance over time, not decline. Because seeing how individuals with severe illnesses who are on death's door can turn around and be revitalized, can we get retired athletes to function at their peak level of performance when they were very young, regardless of their baseline medical condition? That's what we aim to see. These athletes are going to be surprised at the accomplishments that they will make during this program.
Maybe this is something that can help me. So I'm here. I just think it's something that prayerfully that will be a benefit to me and other people as well.
I'm excited. I'm ready to try to do this. It'll be interesting though to see what the change is from where I have started my baseline, right? So that'll be an interesting part to see.
Essentially, the illnesses that Mr. Banks, Green, Mosley, and Wadi are dealing with kill more people every year in the United States than all the deaths that we've lost from American soldiers in United States history.
That's the heart of a champion. The heart and soul of a champion. The heart and soul of a champion. Yeah. The heart of a champion. The heart and soul of a champion. Texas tenor music production.
Okay, I'll probably need you to, can you hear me okay?
Yeah, yes, we can hear you. We can hear you fine.
Okay, so typically I do maybe 2 showings, but I wanted to show that one episode, and what I'll share with the audience before we get into Q&A is the fact that, this docu-series is designed for multiple purposes. One is an educational piece, obviously is an entertainment piece, but the motivation behind this, and not only this season, but future season and ongoing seasons, is to show everyone the inside stories behind, taking care of these patients. For many years, I've come to these conferences and presented our approach to putting people on a plant-based diet and help them reverse their cholesterol and improve their overall health. However, there are many stories behind this, and there's a human factor. And what we hope to show in this first season and continue to show the many different stories behind this, because we all have to put, a face behind, these lives. We talk about statistics of heart disease and the like. But they're real stories, they're real human beings behind this. And chronic illness, and we'll address, all of these aspects. Chronic illness do not just affect the person, who is suffering that disease or diagnosis, but it's affecting the people all around them. And hopefully the docu-series will come and continue to bring the multiple dimensions around these stories that we're dealing with. And so with that, I'll close my comments, and we have quite a bit of time for Q&A. I did this on purpose because I wanted to allow time for a discussion. So I'll let a moderator take over and moderate that.
Thank you so much, Dr. Montgomery, for one, your initial talk, and also that looks like a great show. Where can someone find that series?
There's a link, I think I emailed to you, that is also on my final slide, is heartandsoulofachampion.com.